AIDS ultimately is a syndrome of reduced immunity. As we've discussed, one of its diagnostic criteria is the reduction in immune cells, namely the CD4 cells. As you can imagine, this leads to a lot of problems, most notably a significant concern for all types of infections throughout the body. In addition to new infections that we are going to go over in a minute, AIDS provides the opportunity for past infections that may have remained latent to be reactivated. Some examples include tuberculosis, herpes simplex virus, and varicella zoster virus. These pathogens can return with a vengeance and cause severe disease in those with AIDS. The most highly tested part of this conversation is the new opportunities for infections in patients with AIDS. These are dubbed the opportunistic infections. These infections would not affect a person with normal immune system, but in conditions of AIDS, they are given the opportunity to cause disease. Opportunistic infections in AIDS afflict all parts of the body. There are different ways to organize the infections, and I encourage you to organize them in different ways to learn this material best. Try organizing them by parts of the body affected, group them by bacteria, virus, and fungal causes, and so on. Be creative. The way first aid, and I will review them, is by understanding at what CD4 count these pathogens can cause disease. The CD4 counts of importance include 500, 200, and 100 cells per millimeter cubed. Clinically, this is a good way of organizing the infections because then you have an idea of what to look for when your patient comes in with a CD4 count that you measured on your basic laboratory panel. At a 500 CD4 count, important pathogens to be aware of are 6 of them. They are Candida albicans, Epstein-Barr virus, Bartonella henselae, HHV8, Cryptosporidium, and HPV. A mnemonic I made up to remember these is, can't everyone be happy carrying 500 heavens? Can't everyone be happy carrying 500 heavens? Let's start now by discussing each of the pathogens and talk about what disease they will cause in a patient with AIDS. Now let's go through each of these one by one, and I want you to try to think of what disease these pathogens will cause. Candida albicans is a fungi that can present as oral thrush. Oral thrush is a fungal infection of the mouth with a scrapable white plaque and pseudohyphae seen on microscopy. Epstein-Barr virus will cause a hairy leukoplakia. This lesion can look similar to oral thrush, but the key distinction is that the lesion is unscrapable and is not easily removed. Here's an image of the oral hairy leukoplakia seen on the lateral tongue. This is a white plaque that is unscrapable, which distinguishes it from our oral thrush caused by Candida albicans. Bartonella henselae can cause bacillary angiomatosis, also known as cat scratch fever. The way you diagnose or the findings you see in somebody with Bartonella henselae bacillary angiomatosis is to look for skin lesions and a biopsy with neutrophilic inflammation. Human herpes virus 8 causes Kaposi sarcoma, as we can see in this image here. To diagnose Kaposi sarcoma, you need some skin lesions and also some biopsy with evidence that the HHV virus within the lesions. Cryptosporidium is a protozoa that can cause chronic and watery diarrhea. The best way to diagnose Cryptosporidium infection is by finding acid-fast oocysts in the stool. Human papillomavirus can cause squamous cell carcinoma of the anus or the cervix in women. Remember, the immune system is just as important for controlling cancer as it is for controlling infections. So it's important to look for any sort of malignancy in these sensitive areas in a patient with AIDS. The next important CD4 count to be aware of is the CD4 count of 200. 4 pathogens can appear at this CD4 count, including Toxoplasma gondii, the HIV virus, JC virus, and the Pneumocystis jirovecii protozoa. Toxoplasma can lead to brain abscesses, which show up as multiple ring-enhancing lesions on an MRI. The HIV infection, which also causes AIDS, can lead to an HIV-associated dementia when the CD4 count gets below 200. The JC virus can cause progressive multifocal leukoencephalopathy, which is going to show up as non-enhancing areas of demyelination on an MRI. Do you remember what kind of virus the JC virus is? It is a DNA polyomavirus. Very good. Finally, pneumocystis can lead to a pneumonia that is going to show up with ground glass opacities on chest x-ray, as we can see in this chest x-ray image. If you look at what these pathogens have in common, we can see that 3 out of the 4 of them cause disease in the central nervous system, including toxo, HIV, and JC. The only outlier is PCP, which impacts the lungs. The boards will not ask you to list these organisms on the exam, but they will want you to be familiar with some of the classic diagnostic findings and presentations. Finding ways to group and organize them in any way can be very helpful. Once our patient gets to having a CD4 count of 100 or less, we begin to see the floodgates open. This is when the disease starts to get really bad. If we think back to our graph that we went over a few slides back, we are approaching the end of the course with the CD4 count approaching 0 and the viral load skyrocketing. The infectious processes that are caused at this stage of the disease can be very devastating. In this state, patients can experience diseases caused by Aspergillus, Cryptococcus, Candida, CMV, EBV, Histoplasma, and the Mycobacterium species. I'm going to show you the presentation and findings, and we'll go through them one by one. For patients that are infected with Aspergillus, it's important to remember that this fungi likes to infect the lungs. It can create cavities that can be seen on imaging, can create cavitation or infiltrates on chest imaging, and it most commonly causes hemoptysis and pleuritic chest pain. So far, infections in the lung in a patient with advanced AIDS can include Aspergillus and the pneumocystis pneumonia. Very good. A very serious and life-threatening infection in AIDS is cryptococcal meningitis. Do you remember the classic symptoms seen in a patient with meningitis? You would see fever, headache, neutral rigidity, and photophobia, just to name a few. Cryptococcal meningitis can be diagnosed with CSF fluid showing thickly encapsulated yeast on India ink stain. Do you remember how we would treat cryptococcal meningitis? We could give amphotericin B with flucytosine. Very good. Do you remember what did Candida albicans cause in a patient with a CD4 count of 500? In that scenario, Candida caused oral thrush. As the AIDS advances and the CD4 count gets even lower, Candida can cause an even more sinister esophagitis. In this scenario, we would visualize white plaques on endoscopy with yeast and pseudohyphae present on biopsy. Cytomegalovirus is one of the worst pathogens for patients with AIDS. This little bugger ends up all over the place. It can cause retinitis, esophagitis, colitis, pneumonitis, and encephalitis. And some classic findings include linear ulcers on endoscopy of the esophagus, as well as cotton wool spots on fundoscopy. And the classic finding of the biopsy, remember, includes Al-inclusion bodies. Epstein-Barr virus can cause B-cell lymphoma, which is a central nervous system lymphoma. If you ever hear the words CNS lymphoma, the person has AIDS and the lymphoma is caused by EBV. 9 times out of 10, this is a favorite question on the boards. Histoplasma can cause a systemic fungal infection that leads to a lot of nonspecific findings, as we can see here. Fever, weight loss, fatigue, cough, shortness of breath, nausea, vomiting, diarrhea. To diagnose this patient, you would see an oval yeast cells within macrophages on biopsy. Mycobacterium avium intracellular is a mycobacteria that is very common in patients with AIDS. Do you remember what drugs we can use to prevent this mycobacterial infection? We can use azithromycin and rifabutin. Very good. This mycobacteria causes nonspecific symptoms as well, like fever, night sweats, weight loss, and maybe even a focal lymphadenitis. Those are all the infections. I know it seems like a lot because it is. So please make sure to review this a few more times and try out what I said earlier. Organize these pathogens in unique ways, in different ways that will help you remember them. The prion diseases are the last thing we're going to talk about in the virology section. It is important to note, prions are not viruses, but they are abnormally shaped proteins that can cause a group of rare, fatal diseases that affect the central nervous system. The word prion is an abbreviation for proteinaceous infectious particle, or PRP. According to our early studies, prions are proteins that cause disease but are no different in amino acid sequence from proteins that are found in the normal cell or in the normal cell membrane. Prions are proteins that can exist really in two structural forms. They can exist in a normal or physiologic form and cause no disease, or they can exist in an abnormal or pathologic form and cause a very serious disease. The normal cellular protein is dubbed PRPC, and is comprised mostly of alpha helix Cs with some beta-pleated sheet structures. So if you remember back to our structural biochemistry, do you remember what alpha helices and beta-pleated sheets are? Are they primary, secondary, tertiary, or quaternary structures of the protein? This is a form of secondary structure of protein. In prion disease, the abnormal protein, the alpha helices are converted into beta-pleated sheet structures. This form of the prion, or the protein, is known as PRP-SC. This form of the prion, or the protein, is transmissible and has been found to result in spongiform encephalopathies, significant of dementia, ataxia, and death. The way to think about prions is that they are infectious, abnormally folded proteins. That is it. Unfortunately, these abnormally folded proteins interact with proteins in the normal form and cause them to adopt the abnormal form. This propagates the infection. Here's an image demonstrating this concept. The normal proteins, the PRPCs up here, interact with our abnormal proteins here. They interact together, and as a result, the normal proteins are converted into the abnormal proteins, and these abnormal proteins, or prions, go on to cause the spongiform encephalopathies. The prion diseases include Creutzfeldt-Jakob disease, Gerstmann-Straussler-Scheinker syndrome, and Kuru. Two of these, namely the CJD and Kuru, are acquired by ingestion of prion-containing tissue, beef in the case of CJD, and human brain in the case of Kuru. These diseases cause impaired brain function, memory changes, alterations of personality, and movement abnormalities. The key feature of prion disease is that the dementia develops very rapidly. Age-related dementia, like Alzheimer's or vascular dementia, develops over years and years, while prion-associated dementia develops over the period of weeks to months. Now time for a flash quiz. What is the pathogen responsible for this disease in this HIV-positive patient? As we can see, this here is oral thrush that is caused by Candida. Remember, oral thrush caused by Candida usually occurs in patients with AIDS with CD4 counts of less than 500. At CD4 counts less than 100, patients with Candida infection can get esophagitis. And that concludes the virology section, everyone. Congratulations on finishing a large section in microbiology. You are that much closer to succeeding on your Step 1 examination.